So my project was developing models for public health primary care collaboration to improve older adults' health. Western North Carolina has 19% of the population in Western North Carolina is over 65. That only 13% of North Carolina and the U.S. are over 65. But the U.S. will be where Western North Carolina is now by 2020, which when I started the project was farther off than it is right now. So we have an opportunity to develop models that are important for the whole country. I wanted to do a literature review and see what people had figured out already, and then try pilots that worked in both the existing now healthcare system and the coming healthcare system. Because my mentor, Suzanne Landis, said once prevention pays for itself, healthcare systems will bring the health educators on board. And so then what's the role of the public health department after that? I was impressed when I did my literature review that this was the topic everyone was writing about and no one was agreeing, and few people had come up with a model that seemed to apply universally. But the clinical realm has traditionally been treating individuals for disease, and the public health realm has traditionally been preventing disease among whole populations. So it struck me that there were opportunities to move it, to work together in the zones that people weren't really comfortable, weren't in either's regular realm. Doing primary prevention for individuals or doing disease management for whole populations. So my two projects, my first project was looking at how can providers make referrals to community services, and then my second project was called Boot Camp Translation. It was a community engagement process, health professionals recruiting and engaging community members to together develop community messages that supported clinical guidelines for evidence-based care. The first project, the provider referrals, this is really busy. You're supposed to read every single word on the slide. Had a lot of false starts, but what I ultimately wound up with, we had done a series of focus groups with providers, asking them, what do you like about serving older adults? What do you find difficult? They said, we want to help our older adult patients remain living independently, and that's what our patients want. As they become a little bit more frail, they need community services like Meals on Wheels and other things to bring them in. We don't know what's available. When we don't know, we assume nothing is. How do we find out? So we developed county-specific lists of resources that could help older adults stay independent. Oh, and they also said, and I tried calling 211 and it didn't work. I didn't get information in real time. And so we developed county-specific lists of resources that would both help older adults stay independent and address the geriatric syndromes of dementia, depression, urinary incontinence, fall risk, and advanced care planning needs. So the 5 key things above and beyond disease treatment that are important to address with older adults. We haven't really evaluated the rollout of this program yet. We put these on our website and have shared them in a variety of ways. That'll come in future grants. The boot camp translation, we dovetailed off a project that we were already doing related to heart disease. And we engaged recruited 15 members of the community, and a physician worked with them over a 6-month period. A physician taught them clinical guidelines around heart disease and stroke prevention. Another health educator, Melissa Baker, and I taught them evidence-based messaging, community messaging. They taught us what's important in this community, what values should you tap into with a heart campaign. And then together we developed a message. So it was, your heart attack is in progress, emphasizing urgency. Don't be sidelined, stay in the game, emphasizing what's important in extracurricular sports. We listed the different factors that people could do, and we called the doctor a coach. So you'll see some of that language on your things. Water bottles. Talk to a doctor now. That was really important in this particular community that had traditionally been underserved, where people went to the doctor to die, or went to the hospital to die. So they were getting acute care, and probably not enough of it, but weren't used to thinking of going to the doctor for preventive care. Here are the materials that they helped us come up with. We put up billboards. We created a Facebook page. I thought, older adults don't use Facebook, and I was totally wrong. They set me straight. We developed testimonials of people in the community, local bigwigs, who had engaged in the 6 behaviors we were promoting that they change, and told their story, what they'd struggled with, how they'd overcome it. And then we, on the water bottles, we gave the 6 messages, and we would hand them out at screenings. And then on the Facebook page, we would tell people when screenings were coming up. It was a little bit challenging to evaluate a community-wide initiative, but what we did look at was whether there was better hypertension control among our patients at that practice than other patient practices we run, and there was. 84% of our hypertensive patients at that site were under control versus 77% at another rural site and 55% at our mother big site. So that was exciting news. We got to work on the mother big sites rates. Another thing that I found interesting about trying to bring together public health and primary care, I had thought of it as a bridge and bridging these 2 groups of people. And my colleague Melissa Baker said, no, really it's a lens. We're using different lenses to look at the same problem. And so we came up with this way of characterizing what can public health teach primary care, thinking about geographic populations, not just populations of your patients, thinking about health equity, thinking about aligning community resources and collective impact, root causes of poor health, policy and environmental change, not just individual behavior change, and thinking about health literacy. Just because you prescribe a medication does not mean that your patient is going to get better. Take it and get better. Then what can healthcare teach public health? Accountability, if not to health outcomes, at least to really being very rigorous about what you're doing and the processes you use, being very data-driven. I think that medicine has done a phenomenal job of embracing change and creating a lot of, adopting to a lot of change very fast, and that is something that public health is beginning to do and could also learn from healthcare. Okay, advice to the next Fab 5. Lots of changes going on. All of us have changed jobs over the course of the 2 years. That's made it harder to have a continuous project. So I recommend that you all don't aim for one project that could be interrupted as you have 3 different jobs in the next 2 years, but do small, quick tests within a broad topic. Pick things that you want to develop, skills, and make contacts, and don't expect the end-all be-all to be your project, but more the relationships you build in developing your project. And then also have fun with your colleagues. I don't know if you recognize these pictures. This is Vegas. So there were a lot of times that my colleagues and I would say, okay, we're in Vegas mode. What's said here stays here. And then over there is the cone of silence from Get Smart, which is the same concept. But it was just like overwhelming how much change was going on. And it was really nice to have trusted colleagues that I could try to process this with. And that was one of the biggest gifts to me of the Bernstein Fellowship. I remember learning about Jim Bernstein and feeling very overwhelmed that it was scary to think that anyone thought that I was supposed to try to step into his shoes in any way. But it has been an incredible gift to learn about him, to learn from the mentors and the board members, and also my colleagues, and it's been a wonderful experience. So I second what Amelia said, that you're in for a treat. Thanks.